another thing we have to be careful about.
Yes. Point well taken, madam. Can we have Dr. Soumen, please? Can you share your screen?
Yeah. Very good afternoon. First of all, I'd like to thank AIOC for giving me this opportunity. Am I visible and audible?
Yes, all right. All good.
Yeah, okay. So I'll straight away go to my case. It's a 53 years old lady who had a diminution of vision for 2 years in her left eye. She had had a vitrectomy for macular hole in the left eye in the hospital about a year ago. When she came to us, her best corrected visual acuity was 3/60. And this was the OCT. As you can see, it's a large hole. And these are the parameters of the hole, quite a large base diameter. So I started my surgery. That's a routine 25G pars plana vitrectomy. At that point of time, I used to do 2 valved cannulae and 1 non-valved cannula. As you can see, quite a large hole. I injected the BBG. I tried to stain whatever ILM there was with 2 motives. 1, to do a larger ILM peeling, and 2, to harvest a free flap, if that can be put on the hole. But after numerous attempts, as you can see, that could not be done. I tried in a couple of more places. I couldn't. So finally, I decided to go for a retinal graft. The graft area was demarcated by endodiathermy, and it was surrounded by laser. PFCL was injected. And I attempted to harvest the graft.
Wouldn't it be more difficult to harvest the graft under the PFCL?
Yeah, ideally I should. This was one of my first cases. So, I mean, I wanted to show this video also to see the fallacies of what goes on in these kind of surgeries. Yeah, and as you said, that is exactly what had happened. The graft tried to ride over the PFCL, and I had a hard time trying to maneuver it to go underneath. Finally, after some struggle, I could. Yeah, as you can see, the graft size was inordinately larger than the hole. I was using, as I said, a hybrid port system. My right-hand cannula was a non-valve one. So it came out of the PFCL, and before I could realize, it was lost. Then I decided to have a second graft. And it should obviously be a little smaller than the previous one.
This sure requires a lot of guts.
Yeah, finally it was underneath the PFCL and I could put it at its designated place on the hole. With the graft very well in position, I proceed for fluid air exchange. Now look, the moment I put silicone oil, the graft started migrating. And therefore, under the silicone oil, I had to bring it back in place. Thankfully, my ordeal ended there that day. It had been quite a long day of surgery. And just a minute. Okay. So on the first post-operative week, I was very relieved to see that the graft was still in place. The OCT showed that the graft is in position. This is the 3 months post-operative picture. The graft seems to be well taken. And as you can see, the silicone oil interface. So I did the silicone oil removal after 3 months. Patient visual acuity improved to 6/24. And 1 month post-S1, that's the picture. The graft seems to be very well taken. And I was very happy at last to see the ERG. Thank you.
Fantastic job.
Thank you, Dr. Mandal. Great video. And a very nice learning for, I guess, all of our audience, because losing the graft is something which all of us have at one point of time or the other faced. And it's something which has happened to all of us. But it's a nice learning about how you can go ahead, deal with it. And like you said, I, to be honest, still don't use PFCL, but most of the people do. And I kind of now agree to the fact that using PFCL does make our life a bit more easier when we are doing these cases. But thank you so much for showing that video. And any other observations or any comments from our esteemed panel?
I'd just like to ask how he made sure that he had not inverted the flap.
Well, I think I had to rely on about that visibly. I mean, by my visual impression that I'm putting it on the right side, not the upturned side. And I would also like to corroborate with Dr. Mahesh that later on I learned that if I have to put PFCL while harvesting the graft, I'll have to put it full on, full on PFCL, no partial PFCL. Number one. Number two, while I'm harvesting the graft with my cutter, a significant amount of PFCL gets absorbed, gets sucked by the cutter itself. So if you have a little less PFCL, that will get even lesser and lesser once you are turning your cutter all around. So PFCL has to be more than adequate.
Very excellent video. And it takes a lot of guts to show a video with so many problems. So I must congratulate you on that as well.
Yeah, thank you.